the short sliding movement that we call the gliding movement. We have the angular movements in which I will be either increasing or decreasing the angle of a joint. And if you remember, we classified the angular movements according to whether they are taking place along along the sagittal or frontal plane. And if you remember, the angular movements that are taking place along the sagittal, if I am reducing the angle of the joints, this is what we've called a flexion. If I'm increasing the angle of the joints, this is what I call extension. If you remember, the angular movements along the frontal plane, this was either moving towards the midline, this is what we call the adduction, or moving away from the midline, this is what we call the abduction. We then did discuss another type of movement, which is the rotational movements. And remember, the rotation movement is the turning of the bone around its long axis. And we did see two examples on here. Those are the head rotation and the thigh or femur and arm or humerus rotation. So rotational movements, the head rotation, which is taking place between C1 and C2, and the rotation of the femur and the humerus around their own axis. We also discussed some special movements, like the special movement here that results from the rotation of the radius, not around its own axis, but around the ulna, allowing the pronation and supination movement of the hand. We did see the upward and downward movement of the foot. Remember, an upward movement of the foot, this is what we've called the dorsiflexion. A downward movement of the foot, this is what we call the plantar flexion. Other special movement of the foot that we've seen, if you remember, if you're creating the space between your foot and the ground towards the midline of the body to the inside, this is called inversion. And if you're creating the space between your foot and the ground on the outside away from the midlines, this is what we call eversion. Also, we've seen a special movement of the mandible. This was a forward movement of the mandible. This is what we call the protraction. And the backward movement of the mandible, this is retraction of the mandible. When you move the mandible down, this is called depression of the mandible. When you move the mandible up, this is the elevation of the mandible. A special movement that we've seen in the thumb that didn't exist in the other four fingers. This is what we call the opposition, which you are able to put the thumb opposing the other four fingers. If you remember, according to the shape of the articular surfaces, we've classified the synovial joints into 6 main types. if I have two flat surfaces articulating together, they are not performing any angular movement, but they are performing just a gliding motion. We call this is a plane joint. And remember, plane joints, like the intercarpal joints, the joint between the carpal bones, they allow just a short gliding motion. And those plane joints are non-axial joints. What I mean by non-axial joints, they are not performing any angular movement or rotational movement around or along any axis. So we consider them as non-axial joints. We see in another type of synovial joints in which I have a cylinder that articulates with a concave surface. And the major example on here for this type of joints would be the articulation between the trochlea and the trochlear notch of the ulna. And we call this joint is a hinge joint. So the movement that you can allow by a hinge joint is going to be like in the articulation between the ulna and the humerus. You can perform only flexion or extension of the elbow joint. So a hinge joint allows an angular movement along only the sagittal axis. So we consider the hinge joint as a uniaxial joint. What I mean by uniaxial again, this simply means that you have only one axis that you are moving along. We'll see in another type of synovial joints in which I have a rounded articular surface that articulates within a sleeve or a ring coming from another bone. The example on here is the articulation between the radius and ulna. This is my ulna on here, and this is my radius. Remember, the radius has this rounded part, which is the head of the radius. And following the head, we've got the neck, and we've got the radial tuberosity on here. All right, so what kind of movement are you allowing in this type of joints that we call the pivot joint? Pivot joint, I have a rounded surface articulating within a sleeve or a ring from a different bone. Pivot joint here will allow the rotation of the radius around not its own axis. It's not a rotational movement, but allows the rotation of the radius around the ulna, the axis of the ulna. So as I move the radius, this is how it's going to look like. Remember this movement, if the thumb was in here, as I rotate the radius around the ulna, the thumb moves to this point. So this is the back of the thumb on here. Remember, this is what allowed the pronation and supination movement to take place, the rotation of the radius around the ulna. So if you are performing a pronation movement, touch your radius on the outside, on the same side as your thumb, and perform a pronation, you will feel that the radius is rotating around the ulna. All right, so again, what kind of synovial joint is this? It's a pivot joint. And how many axes I am moving along? I am moving along the long axis of the ulna. I'm performing a rotational movement around the long axis of the ulna. So I have only one axis I'm moving along. It's a uniaxial joint. Another type of synovial joints in which I have one convex articular surface that articulates with one concave articular surface, like this. One convex that articulates with one concave. The rotation here, the lower part. So I've got a question here for Alexandra. The rotation is taking place in the forearm. In the lower part of the radius is rotating around the ulna, but it's not a rotational movement. We call this is pronation and supination. So it takes place in the mid forearm and it's going to be reflected as a movement in the hand. All right, so the hand is the part that actually you can see moving, but the actual rotation is taking place in the forearm. So you cannot say, is it at the wrist or is it at the elbow? Because it's taking place in the forearm, not at the elbow. All right. And the movement itself is going to be reflected as a movement of the hand, pronation or supination. This is for the pivot joint. Again, we're looking here at another type of synovial joints that we've seen last class. This was the condyloid or ellipsoid joint. Remember, I have one convex surface and one concave surface articulating together. So I can perform like the articulation between the proximal phalanx and the metacarpal bone on here. So if I want to see an example of a condyloid or ellipsoid joint, this is my metacarpal bone and this is my proximal phalanx. Let's say this is the midline of the body. So what kind of movements can you perform between this concave and this convex articulating surfaces? You can move towards the midline. You can perform adduction. You can move away from the midline. You can perform abduction. So if I'm standing in an anatomical position, palms are facing forward, my finger can move away from the midline or towards the midline. Abduction, adduction, abduction, adduction, abduction, adduction. Also, I can move along the sagittal line, performing flexion, reducing the angle, or performing extension. So I can perform flexion or extension, flexion, extension, flexion, extension, flexion, extension. So you see here, I can move along the frontal, abduction, adduction, abduction, adduction. I can move along sagittal, flexion, extension, flexion, extension. All right. So condyloid joints will be moving along how many axes? Two. So we call those are biaxial axial joints. So any of them gonna be a good name for this type of joint. So you might use condyloid or ellipsoid joints. Those are interchangeable. They won't make any difference. All right, so you can use any of them. All right, another type of synovial joints that we've seen, it's more complex than the condyloid joints, in which the articulating surfaces, each of them has convex sides and concave sides. So this is one surface area, one surface, one articular surface, and this is another articular surface on here. You see, each of the surface areas, each of the two surface areas will have a concave part and a convex part. This is like the carpo-metacarpal joint of the thumb. This joint here between what carpal bone is this? Do you remember? What is this carpal bone? Remember, we start from lateral to medial. We start with the proximal row, then we go to the distal row. So Sally left the party to take Kathy home. So what was this bone? Exactly, Theodore. This is the trapezium. So the articulation between the trapezium and the first metacarpal bone of the thumb is like this. I have two articulating surfaces in which each of them is gonna have a concave side and a convex side. All right, this is what we call the saddle joint. So what a saddle joint movement can perform, it can perform flexion extension, it can perform abduction, adduction, but remember, thumb also can perform another special movement, which is a combined movement of the previous two, which is the opposition. So how many axes can I allow the movement along in a saddle joint? I can allow the movement of the joint in two axes. We consider the saddle joint as a biaxial joint. The last type of synovial joints that we've seen, it was the articulation between a bowl-shaped articular surface and a socket-shaped articular surface. And we have two major examples in the body of the ball and socket joints. Those are the articulation of the head of the humerus with the glenoid cavity of the scapula and the articulation between the head of the femur and the acetabulum of the coxal bone. Remember, the femur and humerus, they can perform abduction, adduction, they can perform flexion, extension, they can perform rotational movement, medial rotation, lateral rotation. So I have more than 2 axes I can move along, so we call those are multi-axial joints. And this is a type of joints that will allow the widest range of motion, the ball and socket joints. And again, examples here of the ball and socket joints, the shoulder joint and the hip joint, the articulation between the head of the humerus and the glenoid cavity, and the articulation between the head of the femur and the acetabulum. Moving on to the major synovial joints in the body. The first one is the shoulder joint. And again, it's a ball and socket joint in which I have the articulation between the head of the humerus with the glenoid cavity of the scapula. The glenoid cavity, it's a shallow cavity. It's a loose cavity. That's why I need a lot of reinforcements to stabilize the shoulder joint. So we're going to see a bunch of muscles that will be attaching the 2 bones together. If you remember, muscles are acting as what type of reinforcement? Remember, we did have 3 types of reinforcements, either capsular reinforcement, intracapsular reinforcement, or extracapsular reinforcement. So where are the muscles going to be traveling? Are those muscles traveling outside of the joint cavity, inside the joint cavity, or as part of the capsule of the joint? Outside. So those are considered extracapsular reinforcement. So you have a lot of muscles and tendons that will be attaching the scapula to the humerus. And a major example of those muscles, the muscles that we call the rotator cuff muscles. And we're going to see a bunch of them when we start our discussion of the skeletal muscles. Just few examples on here of the rotator cuff muscles. If you remember, this is how the scapula did look like. This is my glenoid cavity. This is my spine. I remember I did have a depression above the spine, a depression below the spine. So those are sites for attachment of 2 muscles called the supraspinatus, the muscles that gets its origin from above the spine, we call it the supraspinatus. And the one muscle that would be getting its origin from the scapula, from below the spine of the scapula, we call it infraspinatus. We have 2 rounded muscles on here as well as part of my rotator cuff muscles. Those are my teres minor and teres major. On the anterior surface, I'm looking at the other side on here of the scapula. I will see on the ventral surface of the scapula, I have another depression that will act as a site of attachment of another muscle called the subscapularis, the muscle below the scapula. All those muscles are attaching the scapula to the humerus. They are responsible to reinforce the shoulder joint. So we've got here This is my subscapularis. Again, all of those muscles are called my rotator cuff muscles. We're going to discuss them in details when we get to the muscles section. You don't have to worry about their names for now. As I have many tendons of those muscles traveling around the articulating bones, so each time I will be moving my shoulder, moving my arm as a shoulder joint, there will be some irritation to the tendons of those muscles. So in order to reduce the irritation, remember, what do we have between the ligaments, tendons, and the moving bones? Remember, we did have sacs formed of a synovial membrane, and they are filled with synovial fluid. What do we call those sacs filled with fluid located between the tendons, ligaments, and the articulating bones? Those are my bursae. So if you're looking here at the shoulder joint, you're going to have many bursae located between the ligaments, tendons, and the bones for them to reduce the friction and to reduce the irritation applied to the tendons and ligaments in this joint. The shoulder joint will allow a variety of movement. This is going to be providing you with a much wider range of movement compared to something like the hip joint, although both of them are ball and socket joints, but the shoulder joint, as it has a loose cavity, it's going to be providing you with a wider range of movement. But on the other side, this is going to be much more easily to be dislocated compared to the hip joint. Why is the shoulder joint, it's much easier to be dislocated compared to the hip joint? Because of the shallowness of the glenoid cavity. The glenoid cavity is too shallow compared to the acetabulum. This gives you one good thing, one bad thing. Good thing, provides you with a wide range of motion. The bad thing, it's easily dislocated compared to something like the hip joint. Moving on to the elbow joint. And the elbow joint, if you remember, it's the articulation between the distal epiphysis of the humerus. And if you remember, in the distal epiphysis of the humerus, we've got this cylindrical shaped articular surface. We call it the trochlea. And we've got this spherical articular surface. We call this is my capitulum. And those are the two articular surfaces that were articulating with my radius and ulna. If you remember, the trochlea articulates within the trochlear notch of the ulna. And the capitulum articulates with the head of the radius. So again, what are the two joints that are forming my elbow joint? I have the articulation between the trochlea of the humerus and the trochlear notch of the ulna. and the articulation between the capitulum and the head of the radius. What are the types of synovial joints on here? If you remember, can you remind me what is the type of synovial joints that you have between this cylindrical shaped articular surface and the concave articular surface? You remember, we mentioned it a few minutes ago. What do we consider the synovial joints? The synovial joint in which I have a cylindrical shaped articular surface articulating with a notch. It's a hinge joint. So you have a hinge joint, So a condyloid joint, I have one convex and one concave. This is a condyloid. But a hinge joint, I have one cylindrical and the other one is concave surrounding this cylinder. So it's a hinge joint. So the articulation here between the trochlea and the trochlear notch is a hinge joint that allows the flexion of the elbow, flexion of the forearm. Compared to, you see on here, I have two flat surfaces, almost flat surfaces between the head of the radius and the capitulum of the humerus. So we consider this as a plane joint. So this plane joint allows just a gliding motion that takes place between the head of the radius and the capitulum to allow what movement to take place? To allow the rotational movement of the radius around the ulna, allowing the pronation and supination movement. So the movement that takes place between the capitulum and the head of the radius is a simple gliding motion, but this gliding motion is necessary to allow the rotation of the radius around the ulna. All right. Joint capsule also going to have many ligaments that will reinforce it to prevent the elbow dislocation. You will see the radial collateral ligament, the ulnar collateral ligament. You're going to see this annular ligament that will be acting as a ring between the ulna and the radius. So many ligaments on here gonna be reinforcing the elbow joint to prevent its dislocation. All right, so for the first in-class activity for today, for the first question today, what type of synovial joints allows gliding motion? What type? Ball and socket, what do you think? Ball and socket? Ball and socket, remember, it allows flexion extension, abduction adduction, and rotational movement. So no gliding movement. Pivot joint, it allows the rotation of the radius, if you remember, around the ulna. It's not a gliding motion. It's the rounded surface articulating within a sleeve or a ring from another bone. This is my pivot joint. Hinge joint, cylindrical shaped surface articulating with within a concave surface. It allows flexion and extension. So it's not a hinge joint. Saddle joint, remember, one articular surface gonna have convex and concave, and the other one has convex and concave surfaces. So the articulation between those two surfaces will allow flexion, extension, abduction, adduction, and extra movement, which is the opposition. So no gliding motion here as well. The one that allows gliding motion is the one that is formed by two flat surfaces. And remember the type of synovial joints in which I have two flat surfaces articulating together. This is what we call a plane joint. Plane joints, allowing just a short gliding motion. Exactly. Right, moving on to our next synovial joint of the body. This is going to be the hip joint. And again, the hip joint is a ball and socket joint between the head of the femur and the acetabulum of the coxal bone. If you notice on here, in order for me to make the acetabulum even deeper, for me to have a better reinforcement and better stabilization of the joint, remember, this joint is holding all your body weight down. It's transmitting the body weight from your axial skeleton to your legs. All right, so remember, you have a lot of pressure applied on this joint, so it's better to be reinforced rather than dislocated. So in order for me to have better reinforcement, you will see that the acetabulum is going to be surrounded by a thick fibrocartilage ring called the acetabulum labrum. All right. Also, it is going to have a heavy joint capsule. And remember, the hip joint being a ball and socket joint is going to allow various movements like flexion, extension, abduction, adduction, and rotational movement of the thigh. But remember, it has a narrow range of motion compared to the shoulder joint. Again, why? Because the acetabulum is much deeper compared to the glenoid cavity of the shoulder joint. Moving on to another famous synovial joint of the body. This is going to be the knee joint. And if you remember, the knee joint is going to be the articulation between three bones. I've got the distal epiphysis of the femur with its two condyles and its patellar surface. They are articulating here. The medial and lateral condyles of the femur are articulating down here with the medial and lateral condyles of the tibia. Medial and lateral condyles of the femur articulating with the medial and lateral condyles of the tibia. We also have another joint between the patellar surface, this flat surface in the anterior aspect of the lower end of the femur. It's going to be articulating with this triangular shaped bone called the patella. And remember, between the patella and the patellar surface, we have a short gliding motion. It's a plane joint. I have two flat surfaces. One surface is for the patella, and the other surface is going to be for the patellar surface of the lower end of the femur. So the movement that you allow between the femur and the patella is just a short gliding motion. It's a plane joint. So if you touch your patella right now, your kneecap, and you try to move it, you will see a very short gliding motion that takes place. Why again? Because this is what type of joints between the patellar surface and the patella. What kind of synovial joints do I have in here? Anybody? It's a plain joint, plain joint. Many reinforcements that we do have here for the knee joint. This includes the anterior and posterior cruciate ligaments that will be attaching the tibia to the femur directly. And if you notice on here, we have two fibrocartilage rings. If you remember, when we studied the tissues, we mentioned that we have fibrocartilage in two major locations: intervertebral discs between the vertebrae of the spine and in the knee. And remember, what was the function of the fibrocartilage? What was the function of the fibrocartilage? To absorb compressive shock. So those are the two fibrocartilage rings that I have in the knee joint. And those are my medial and lateral menisci. So those are semilunar cartilage rings that I have between the femur and the tibia that will allow you to absorb the compressive shock. Several berthae can be seen here between the different ligaments, tendons, and the articulating bones, again, to reduce friction and reduce the irritation of those ligaments and tendons surrounding the joint. Moving on to another synovial joint, one of the most famous synovial joints to be dislocated. Actually, this is the most common synovial joints that gets dislocated. It's my temporomandibular joint. The temporomandibular joint, if you remember, this was the articulation between the mandibular condyle of the mandible and the mandibular fossa of the temporal bone. What movements do I have in here? I have a hinge movement that takes place, hinge movement, that allows the depression and elevation of the mandible. Also, I have a short gliding motion that will allow me to move my mandible from side to side. All right, so I have hinge movement, allowing depression elevation. And if I'm considering the middle parts of the two articular surfaces, they are flat surfaces. They allow just a gliding motion from side to side. All right, so if you're drawing here just one mandibular condyle like this within the temporal bone, if I'm passing in the midline, this is how it's gonna look like. So you have two flat surfaces that will allow side-to-side movement of the mandible. Compared to here, what I see a concave part, this is my mandibular fossa, and the cylindrical shaped part, this will be the mandibular condyle that will allow the depression and elevation here of the mandible. Again, temporomandibular joint is going to be the most easily dislocated joint in the body. So why is it the most easily to be dislocated? Because simply you don't have much reinforcements. Not much muscles and tendons are attaching the temporal bone to the mandibular bone, like for example, what I have between the humerus and the scapula, like what I have between the coxal bone and the femur. So in the hip joint, I have much more reinforcement. In the shoulder joint, I have much more reinforcement compared to the reinforcement I have in my temporomandibular joint. All right, for the second question, for the in-class activity for today, what type of synovial joint allows opposition? What type of synovial joint allows opposition? You remember, the ones that allows opposition is my saddle joint, which is located in my thumb, the carpometacarpal joint of the thumb. All right, moving on to the common joint injuries. First type of joint injuries that we're looking at today is going to be the sprains. The sprains are the name given to the stretched or torn ligaments. If I have a partial tear of a ligament, it can repair itself. But if I have a complete rupture of a ligament, so if the two parts are not attached at all, and I have a complete rupture of the ligament, this requires a surgical repair. So again, if I have a partial tear of a ligament, they can repair themselves slowly. But if a person had a complete rupture of a ligament, this requires a surgical intervention and surgical repair of this ligament. Cartilage tears, those most likely going to be due to compression and shear stress. The problem with the cartilage tears is that those fragments of cartilage that will be dislodged from their place might cause joint lock. So if I have a cartilage part that got dislodged from its place, it's going to be preventing the joint from moving. The other problem with the cartilage tear is that the cartilage rarely repairs itself. Why do you think? What is the characteristic of a cartilage tissue that can explain that the cartilage rarely repairs itself? It's avascular, exactly. It's avascular. It doesn't have blood vessels, so the cartilage can't regenerate. It doesn't get enough blood supply, doesn't get enough nutrients, enough cells, enough oxygen. It's avascular. That's why it's almost impossible for the cartilage to repair itself. All right, so what we're gonna be doing if a person got a fracture of a cartilage? We're gonna be removing the fragments of the cartilage by an arthroscopic surgery. Try to put them in place if they are large enough. For the smaller fragments that got dislodged from their place, they need to be removed. Arthro means joint, and scope means vision. So I'm passing to the inside of the joint using an endoscope to perform my surgery. So it's not an open surgery, it's through a camera that gets inserted in the joint cavity for you to perform the surgery, the surgical repair. So you see on here an example of a ligament sprain and a cartilage tear. So I got a lateral trauma to the knee joint on here. This caused the tibial collateral ligament to be torn, as well as the medial meniscus, which is a cartilage. Other common joint injury might be is a joint dislocation or a luxation. A joint dislocation is simply a force, the bones are forced out of their normal alignment. So for example, when I say dislocation of the shoulder joint, what do I mean by this? I mean by this that the head of the humerus did leave its normal alignment within the glenoid cavity. So rather than being located in here, it moved outside of the glenoid cavity like this. This is what we call a dislocation. The dislocation is going to be accompanied by sprains, inflammation, and joint immobilization. Because remember, I have a bunch of muscles that are attaching themselves to the humerus. So whenever I have a dislocation, there will be a stretch of their tendons and there will be stretch of the ligaments that are attached to the bone. And this stretch might cause the ligaments to be torn or just get inflamed. And if I have inflammation of the tendons and ligaments around a specific joint, whenever I try to move this joint, I will feel pain. So this is going to result in joint immobilization. I can't move my arm because simply I have inflamed ligaments and tendons due to the dislocation. Dislocations or luxations going to be caused by serious falls or playing sports in most of the cases. A less severe form of a dislocation, it's called subluxation. It's a partial dislocation of the joint, in which I can force the bone out of their normal alignment, but without having to deal with the inflammation sprains. It's going to be some kind of overstretch to the ligaments and tendons. Another homeostatic imbalance that will be related to the joints is going to be the inflammation of the bursae and the tendon sheath. If you remember what's a bursa, the bursa was this sac of synovial membranes that is filled with fluid located between the ligaments and the articulating bones, and their main function was to reduce the friction between the ligaments, tendons, and the articulating bones. So for example, a person is bored in class, so he is sitting like this, his elbow is sitting on the desk all day long. So what he's gonna have, he's gonna develop an inflammation of the bursa in his elbow. We called the inflammation of the bursa is a bursitis. Itis means inflammation, and bursa is the membranous sac filled with synovial fluid. Why did I have inflammation of the bursa here? Putting my elbow all day long on the desk like this because of the friction I'm applying on my bursa and the compression, which irritates the membrane and become inflamed. Treatment is going to be rest, and we're going to be using ice to reduce the inflammation. And if severe, we might consider using anti-inflammatory medications. The tendonitis is the same exact concept. So if you remember, the tendon sheath is an elongated bursa that will be surrounding my tendons. With overuse of the muscles, this gonna cause severe irritation as I keep using my muscles. So for example, you go to the gym and your trainer tells you you need to exercise for 20 minutes your biceps, or 10 minutes, or whatever number of counts. So you decided to exceed this number of counts and you decided to exercise rather than for 20 minutes, you decided to exercise for 2 hours. So this can cause an overuse of the joint, causing irritation to the tendon sheath surrounding the tendons. And this irritation will result in an inflammation of the tendon sheath that we call tendonitis. So tendonitis is not an actual inflammation of the tendon, but it's an inflammation of the tendon sheath, which is the bursa-like structure surrounding the tendons that normally is going to be responsible to reduce the friction between your tendons and the surrounding bony structures. So with overuse, what happens is the tendon sheath itself gets inflamed, resulting in tendonitis. Symptoms going to be similar to the bursitis, and the treatment is going to be the same as what we're going to be doing with bursitis. So you need to rest, put ice, and anti-inflammatory medications if it was severe. Moving on to arthritis. And again, arthro is joint, and itis means inflammation. This is an inflammation of the joint. This is a very broad term. This is not the single disease. We have more than 100 different types of inflammatory and degenerative diseases that are damaging the joints. This is the most widespread crippling disease in the US, and all types of arthritis are going to be characterized by having pain, stiffness in the joint, swelling of the joint. We classify the arthritis into two major categories. Those are the acute arthritis and the chronic arthritis. Acute arthritis, it's a sudden inflammation of the joint. Most likely it's going to be due to a bacterial infection. And the treatment for a bacterial infection is going to be to use chemotherapeutic agents. And the most prominent ones of them, those are the antibiotics. Compared to chronic forms of arthritis, those are taking years. So a person would have a problem with his joint. It gets inflamed for years. Sometimes gets better, sometimes gets worse. And this includes the osteoarthritis, the rheumatoid arthritis, and the gouty arthritis. Those again are three of the most common chronic forms of arthritis. Starting first with osteoarthritis. From its name, osteo means bone, arthro means joint, itis means inflammation. So what I can understand just from the names, this is an inflammation of both the joint and the bone, osteoarthritis. It's a common irreversible degenerative arthritis in which I have broken down the cartilage. It is so common, so almost 85% of all Americans will develop osteoarthritis. It's more common in women than men. Some were related to age. So we say that it's a normal aging process, like hair thinning, for example, like wrinkles. So we say that almost everybody gets osteoarthritis. So it's gonna be a normal aging process in which I will be breaking down the cartilage more than what I am building up. Here I have more destruction of the cartilage than what gets replaced. Most likely will affect badly aligned joints or overworked joints. Whenever I have an increase in the destruction of the cartilage covering the articular surface. So let's see this as an example here. This is my knee. The condyle of the femur is covered with cartilage. The condyle of the tibia is covered with cartilage. So osteoarthritis, I have over-destruction of the cartilage. So now the bony ends are articulating against one another. As I did destroy the cartilage layer, now I have two exposed bony ends articulating against one another. So what's going to happen? Remember, what was the importance of having cartilage covering the articular surfaces? Do you remember? What was good about having cartilage covering the articular surfaces in my synovial joint? Something that we've stated last session. Cushion and lubrication, something other than lubrication. Lubrication was mainly the synovial fluid. But remember, what was the importance of having cartilage instead of having two bony surfaces articulating against one another? No pain. Actually, the joint itself is rich in nerve fibers. Reduces friction. It's not the role of the cartilage to reduce the frictions. Reduction of the friction was the role of the synovial fluid located in here, in between the articular surfaces. Something that we've mentioned about the cartilage. Remember, cartilage, a very special characteristic of the cartilage that it is something that starts with A, V, vascular. And remember, what is the importance of having my articular surfaces covered with an avascular tissue? It doesn't get inflamed, because inflammation is dilation of the vessels. So if I have broken down the cartilage, now the bony surfaces are articulating, rubbing against one another. So what's going to happen? Those bony ends going to get inflamed. They will become thickened, enlarged, and they will be broken down in smaller pieces. And those small bone pieces will result in restriction of the joint movement. So again, why do I have, it is necessary to have cartilage covering my articular surfaces? Because the cartilage is avascular. It doesn't get inflamed on its own. What gets inflamed is something nearby, ligaments, tendons, bone, but the cartilage itself doesn't get inflamed. Why? Because it doesn't have blood vessels, and inflammation, it's a dilation of the blood vessels. So the good thing is that it doesn't get inflamed, but the bad thing is that it is very hard to repair itself. Remember, it's almost impossible for the cartilage to heal on its own. Why? Because it's avascular. But what is a good thing about being avascular? It doesn't get inflamed. You're running all day long, you're rubbing the cartilage surfaces, your joints are fine. You don't get inflammation of the joint, although you are putting a lot of irritation to those articular surfaces. If I did have just bone against bone, what's going to happen? My exposed bone ends going to be inflamed, going to be thickened, enlarged, and broken down. All right, does this make sense? All right, great. So again, what is the first problems that I'm facing with osteoarthritis is I did break down more cartilage than what I am building up. And this again gonna be exposing the bone ends, which will become thickened, enlarged, and the joint will be not able to move. I will have a restricted movement of the joint. So treatment for osteoarthritis, we highly recommend moderate activity. What kind of activity would you like to recommend to a patient with osteoarthritis? What do you think? What kind of exercises would you recommend? Walking? But walking will put a lot of stress on the knee joint, right? Hip joint. Swimming, yeah, swimming. Why swimming is much better? Because you don't have to hold your body weight. In the same time, you are activating the muscles, because as you activate the muscles will become stronger and they will be providing much better support to the joint. So rather than walking, exercise underwater. If you go to the gym, you will see a group who are performing exercises in the pool. Those people are understanding the benefit of activating the muscles without putting stress on their joints. All right. You're going to be using mild pain relievers just to reduce the pain. We're going to be trying to give creams and ointments that will be enhancing the synovial fluid formation for us to reduce the irritation applied to the articular surfaces. In very severe cases, the best treatment is going to be to perform a joint replacement, so knee replacement, hip replacement, and so on. Yeah, those people behind me, this is a picture. All right. All right. So again, what would you recommend? What would you recommend here? Would you recommend glucosamine sulfate, you recommend chondroitin sulfate to enhance the synovial fluid to build up and reduce the irritation and the friction between the articular surfaces. In more advanced cases, we might be using, if I was faced by persistent inflammation of the joint, some people might consider using injections of corticosteroids, cortisol injection to reduce the inflammation. Collagen supplements, they won't help if it was like already a patient suffering from osteoarthritis. So it's not going to be a treatment. There are theories that are not tested scientifically or proven by evidence that those collagen supplements gonna aid in preventing osteoarthritis. It can get better. It definitely will be better with treatment than without, but it won't be cured. So does it get better overall? No, but it gets better with management, with treatment, rather than without. If you're comparing with treatment and without, with treatment gonna be with much less pain, much less inflammation, but the joint itself will not be repaired. All right. So having 85% of the general population, or 85% will theoretically have osteoarthritis at a certain point in their life, make it one of the most commonly debilitating diseases in the US. So at least you know somebody, if not you, you're gonna know somebody who has osteoarthritis. It's not something uncommon. So this is something that if you have 100 friends on Facebook, at least 50 of them will have osteoarthritis. All right. This is something very, very common. Moving on to another chronic arthritis. It's rheumatoid arthritis. Rheumatoid arthritis is a chronic inflammatory disease. It's an autoimmune disease of unknown cause. Many theories, but still no definitive etiology for rheumatoid arthritis. Might be multiple contributing factors that result in rheumatoid arthritis. Usually arises between age 40 and 50. It's 3 times as many women as men. So osteoarthritis was also more common in women than men. Here is another disease which is more common in women than men. Signs and symptoms include non-specific inflammatory symptoms like joint pain, swelling, but the important characteristic here is that it takes place bilaterally. So being an autoimmune disease means what? Means my body started to recognize my own tissues as non-self. So I started to attack the joint, attack the synovial membranes, as if they were bacteria, for example. So I start to form immunoglobulins, form antibodies that will attack the synovial membranes, causing inflammation of the joint. So those antibodies are traveling with the blood to everywhere. So both sides of the body are going to be affected similarly. So It's a bilateral disease. It affects the joints on both sides of the body. All right. Also, it's not only affecting the joints, it affects the bone, causing osteoporosis, it affects the bone marrow, causing anemias, affects the muscles, causing muscle weakness and cardiovascular problems. This is how the deformity of the joint gonna look like with rheumatoid arthritis. You see major inflammation causing major deformity of the joints that so surgical repair might give you a better appearance, but it will not restore the joint function. All right. With rheumatoid arthritis, we have two lines of management. We have a line that we're going to be keeping all the time. We're going to be using aspirin. We're going to be using antibiotics. Why do we use antibiotics? To prevent any bacterial infection. But it's not an infection for us to use antibiotics as a treatment. We are preventing any infection from taking place to prevent the immune system from being activated to attack the infection. And once it attacks the infection, forming antibodies, it's also going to be activated to release more immunoglobulins and antibodies that will attack my joints. So as a preventive measure, I want to reduce any risk of getting an infection for me to not have activation of my own immune system that mistakenly attacks my tissues. Physical therapy also is going to be part of the conservative therapy. Progressive treatment, whenever I have flare-up of the inflammation, progressive treatment is going to be needed. This includes anti-inflammatory drugs stronger than aspirin, something like cortisol, and immunosuppressants to suppress the immune system to reduce the attack to on the joints. New biological response modifier drugs are going to be used now to a less extent to target specific inflammatory chemicals. So I'm trying to reduce inflammation. I'm trying to suppress the immune system, force the immune system to not attack my tissues, including the joints. And again, the inflammation of the joint in here is going to be what we call the rheumatoid arthritis. All right, so another chronic arthritis that we have, right? So this time it's not common in women, it's common in men, right? For those who are angry. This time it's not common in women. It's more common in men. Gouty arthritis is due to high levels of uric acid. And uric acid is resulting from the metabolism of the nucleic acids, DNA and RNA. Did you eat DNA and RNA before? What do you think? Yes. Did you try DNA before? Before the lockdown, did you want to get DNA, to eat DNA? No? Yeah, you eat DNA in everything that you eat, all right? So If you're eating meat, you are eating the cells, muscle cells of a cow, of a chicken. And inside those cells, you have the DNA, right? You have the RNA inside the nuclei of those cells. If you're eating vegetables, you're eating the genetic material in the cells of those vegetables, and so on. So do we eat DNA and RNA? Yes or no? Yes, we do eat DNA and RNA. And as we metabolize the DNA and RNA, this is going to result in the formation of uric acid. When uric acid blood levels are elevated, they will start to precipitate within the joint cavities. So between the articulating bones, if you remember, a synovial joint did have a shallow cavity between the articulating bones. And remember, this cavity was filled by synovial fluid. And remember, this synovial fluid is extracted from the blood. So if I have high uric acid in the blood, the uric acid also is going to be high in the synovial fluid. And as this uric acid accumulates within my joint cavities, it will start to form urate crystals within the joints. It's like having sand, to give you a feeling about what those joints gonna be facing. All right, so as if you're having sand in your shoes and you're walking. This is the same exact feeling. So you've got crystals of uric acid, urate crystals within the joint cavity. So every time you're gonna be moving the joint, those crystals gonna cause the irritation of the cartilage. And this gonna progress to cause inflammation of the bone as well. Why do people have uric acid elevated levels in their blood? This is mainly an inherited disease. All right, so some people tend to have higher uric acid. They don't get rid of it as they should. So those high levels of uric acid in the blood gonna start to accumulate within the joint cavities, forming crystals, causing the irritation of the joint. One of the most common joints to be affected in the gouty arthritis, it's gonna be the tar, the tarsophalangeal joint of the big toe. This is one of the most common sites for gouty arthritis. If left untreated, this is going to cause joint destruction. See, this is how big those urate tophi can get. See, they can become that big. See here, inflammation of the joint between the tarsal bone and the proximal phalanx of the big toe. All right, so what would you recommend those patients? Avoid any excess alcohol, because as a metabolic product of the breakdown of the alcohol, you're gonna be forming uric acid. So you want to avoid alcohol. Also, we recommend those patients to drink lots of water to clear the uric acid in the kidney rather than being accumulated within the joint cavities. So recommend lots of water, recommend those patients to avoid excess alcohol consumption. Also, we recommend the patients to avoid food with high uric acid content. Those are such as liver, kidney, sardines. So we're trying to do a reduction of the intake of DNA and RNA, simply speaking. So I want to get less number of cells. And the less number of cells that you're taking, the less DNA that you are ingesting. All right, so what would you recommend those patients to eat? Try to prevent meat, try to prevent. So if everything has DNA, what those patients should eat? What do you think? It's not only vegan, because if you did eat beans, each of them gonna have its DNA. So it's not about being vegan. It's about reducing the number of cells that you are ingesting. So we would recommend them to eat something here like an apple, for example. How many cells are in an apple? Do you know? Just one, right? It's a fruit. It's like the egg. How many cells in an egg? Just one. Just one cell. It's actually half of a cell. If it's fertilized, yes, it becomes a cell, but actually it's half of a cell, right? So it has a limited amount of DNA because it doesn't have much genetic content. It's the same for large fruits, large veggies. All right. So we are trying to reduce the number of cells. As you reduce the number of cells, you're going to be reducing the amount of DNA, amount of DNA and RNA to reduce the uric acid. So apple, yes, it will have sugar, but my concern with this patient is the gouty arthritis, high uric acid. So with this patient, I'm more concerned with the uric acid right now. Treatments include non-steroidal anti-inflammatory medication and steroidal anti-inflammatory like the glucocorticoids. All right. Any questions? Any questions? Any